Hi, we're exercise science students here at YSU, and we're going to be analyzing the heart's functionality and rhythm through EKG analysis.
Some points of interest in this presentation are we're going to be looking over the normal function, first degree atrioventricular block, left and right bundle branch blocks, injury and ischemia, myocardial infarction, and sinus tachycardia. With normal rhythm, we're going to be going through the pathway, and the pathway of the electrical system through the heart goes from the sinoatrial node, which acts as the pacemaker. Action potentials are fired from the specialized cells in this area. This is influenced by the autonomic nervous system, aka like the vagus nerve parasympathetically, and catecholamines sympathetically. The atrioventricular node, or AV node, acts with a slight delay to allow the ventricles to fill. Next, the signal goes through the bundle of His. This is the pathway in the walls of the heart of the ventricles, and from there it goes to the Purkinje fibers, which the nerve impulse divides into left and right branches and causes ventricular contraction. This is a picture of the normal rhythm. As you can see, the first thing on the normal rhythm is the P wave, which is in green. And then there is the PR segment, and from the PR segment this goes into the QRS complex, the ST segment, and the T wave. And from the QRS complex to the end of the T wave is called the QT interval. So what does all this stuff mean? The P wave means this is when the atrium of the heart are depolarized. This is also the depolarization of the SA node. The QRS complex means that this stage is when there is depolarization of the ventricles. The T wave is repolarization of the ventricles. The segments are separated into the PR segment and the ST segment. The PR segment is the time it takes for an impulse to travel from the SA node to the AV node. The ST segment is a period when the ventricles are depolarized. And then there's intervals as well. There's the PR interval and the QT interval. The PR interval is the time the electrical impulse takes to travel from the sinus node through the AV node and entering the ventricles. The QT interval is time for both ventricular depolarization and repolarization to occur. And these are what you're going to be able to tell if there's some sort of block or any type of physiological problem with the heart if any of these are abnormal. So with the normal rhythm, here you can see the nice P wave, the PR segment, the QRS complex, the T wave, and the ST segment, which is from the last of the QRS complex to the end of the T wave. The PR interval is from the P wave, from the end of the P wave to the beginning of the QRS complex, and the QT interval is from the end of the QRS complex to the end of the T wave. The first physiological problem we're going to be talking about is the first degree AV block. This is when there's a problem with the electrical system of the heart, which is there's an overly active vagus nerve. The vagus nerve acts to slow the heart. There is also a delay between the contraction of the atrium and ventricles. And when this happens, this means that there's a delay between the atrial depolarization and the ventricular depolarization. This occurs at the AV node. The first degree AV block risk factors include, there are two types actually. There's congenital and acquired. Congenital is when you're born with it, and acquired is when it develops sometime during your lifetime. Acquired is actually more common. Risk factors are if you're a pregnant woman with an autoimmune disease, this is what causes the congenital type. If you have had a heart attack, or also called a myocardial infarction, and also if there's a diagnosis of the following diseases: coronary artery disease, rheumatic fever, myocarditis, heart failure, cardiomyopathy. Some other risk factors also include surgery, medications, exposure to toxic substances. First-degree AV block does not usually show severe symptoms, but second and third-degree AV block does. Some of these symptoms actually include fainting, dizziness, fatigue, shortness of breath, and chest pain. When we look at the EKG, like I said before, there's a problem with the electrical system of the heart. When we look at the EKG, what we look for is a prolonged PR interval of longer than 200 milliseconds. This is measured from the P wave, which is the atrial depolarization, to the beginning of the QRS complex, which is the ventricular depolarization. A normal interval is between 120 and 200 milliseconds. The problem is determined to be marked when the interval exceeds 300 milliseconds. On this picture, we are able to see what a normal EKG rhythm looks like and what a first degree and second and third degree AV block look like. When we take a look at the first degree AV block EKG, as you can see with a normal rhythm, there's hardly any space between the P wave and the QRS complex. But with the first degree AV block, you can see there is an extended line, which is the PR interval, and this indicates that there is a problem with a delay in the signal of the heart. With second degree AV block, now this is obviously more severe, you can see there's a long time before the first P wave and the QRS complex. And then the third degree, the problem is much worse. You can actually see multiple P waves in there. That's just because the signal is traveling and the heart wants to beat but can't because there's a delay in the signal. Now we're looking at the first degree AV block. On here, the first degree AV block is signified by the extended PR interval, which is there's a long gap between the P wave and the QRS complex. This represents the there's a delay between the atrial depolarization and ventricular depolarization. As we stated before, this can be an AV block is classified when this interval is longer than 200 milliseconds. The next thing we're going to talk about are the left and right bundle branch blocks. The left and right ventricles have to contract at the same time in a normal heart. Nerve impulses travel from the AV node to the bundle of His and to either side of the heart to the Purkinje fibers. A block forces the impulse to go a different route. The block forces a slower contraction of one ventricle compared to another, and it is difficult for the heart to pump efficiently through the circulatory system. Because if you think about it, if the timing is off, filling time may be compromised in both the atrium and ventricles, throwing off stroke volume and consequently cardiac output. Some symptoms of the left and right bundle branch blocks are presyncope, or a feeling of being faint, syncope, fainting. Bradycardia may also be a factor, but you may feel like you are going to faint because there is not enough oxygen-rich blood being delivered to small parts of the heart. Some risk factors of left and right bundle branch blocks include a diagnosed coronary artery disease, cardiomyopathy, and valve disease. If you have also had a heart attack or electrolyte imbalance, this can also lead to some sort of bundle branch block. With electrolyte imbalances, Na+ is actually an electrolyte that the body needs. It plays a key role in conducting signals by causing the impulse to reach threshold so the nerve can fire a signal. Some prevention of the left and right bundle branch blocks include if there's another diagnosed problem with the heart, then it definitely needs treatment. Those with diagnosed cardiomyopathy may need cardiac resynchronization therapy if they have the bundle branch block and the cardiomyopathy. But the bundle branch block alone usually does not need treatment. If it's bad enough, then the patient will be treated with a pacemaker to keep the rhythm of the heart. When we look at the EKG of the left and right bundle branch block, we look for a wider QRS complex, and this signals ventricular depolarization, and this means that the ventricles are taking longer to fire the impulse and to contract. So on the left-hand side, we can see a normal QRS complex, but on the right, we can see a wider QRS complex. So now we're talking about left and right bundle branch blocks. And when we look at the EKG, we can see a significantly widened QRS complex. This signifies that when there is a block, there is a delay between the electrical signal and the contraction of the heart, because the signal has to take a different pathway since there is some sort of blockage along the way.
The third problem we're talking about is myocardial infarction. I'll be calling that MI. This is also known commonly as a heart attack, and it's destruction of the heart tissue resulting from obstruction of blood supply to the heart. So the heart is supplied with oxygenated blood by the right and left coronary arteries. And if there's any diseased portion of the arteries from, say, atherosclerosis, which will cause blockage and plaque buildup, blood is restricted from flowing in the heart. And this will result in the myocardial cells not getting oxygenated blood and becoming ischemic, and then possibly getting more damage and even death. Here's an example of myocardial infarction, and you can see that the artery is blocked by atherosclerosis, usually lipids or cholesterol, and down there by the anterior infarction labeled, you can see how dark it is, and this is because of the death of the myocardial cells. Myocardial infarction symptoms can usually occur at any time, and some can strike fairly sudden. Warning signs and symptoms can occur hours, days, or weeks in advance. So it's always reasonable to see a doctor when symptoms begin, because this can be preventable, and sometimes people don't try to see a doctor because they think it's just indigestion or possibly heartburn. Some other symptoms: pressure on the chest or squeezing pain, pain in the shoulder, arm, back, jaw, or teeth, increasing chest pain, shortness of breath, sweating, fainting, nausea, or vomiting. MI occurs when one or more of the coronary arteries becomes blocked. Like I said before, arteries become narrowed from a buildup of cholesterol, and this is known as atherosclerosis. When coronary arteries narrow due to atherosclerosis, the condition is usually known as coronary artery disease. But other causes that are not as common can be a spasm in the coronary artery from use of drugs like cocaine, or a tear in the heart artery, or possibly tumors from cancer. Some heart attack risk factors are age would be for men would be greater than 45 and women greater than 55. Smoking, diabetes, high blood pressure, high blood cholesterol, family history of heart attacks, lack of physical activity, obesity, stress, and illegal drug use. Myocardial infarction prevention. Usually you want to have regular medical checkups with your doctor. Don't smoke, check cholesterol level, manage your blood pressure, exercise regularly. This will improve your heart muscle, and usually when there's MI patients in a hospital, the major component of cardiac rehab programs are exercise. Eat a heart-healthy diet, which would be low in fat, cholesterol, and sodium, and manage your stress. Looking at the myocardial infarction EKG, you can see that this can occur in different portions of the heart, including the anterior, inferior, and lateral portions of the heart. Here's an image of the lateral wall myocardial infarction, which is showing an ST segment elevation, as well as an anterior wall myocardial infarction, which also shows an ST segment elevation. There's also several times you can see peak T waves and significant Q waves, which would be higher than they usually are. This is an example of the inferior myocardial infarction, and this shows also ST elevation from the third lead of an EKG. And now we're going to be looking at myocardial infarctions on the EKG with ST elevation. So we don't really have anything for the myocardial infarction, but we did find ST elevation on the rhythm simulator. So if you can look at lead 2, you can see how the ST segment is a lot longer than it should be, as well as the Q wave being significantly higher than it should be as well. The next syndrome we're going to be talking about is sinus tachycardia. This is known as a harmless rhythm in which the rate of impulses arising from the sinoatrial node, or SA node, is elevated. The normal heart rate has been considered historically to range from 60 to 100 beats per minute. Sinus tachycardia is defined as a sinus rhythm with a rate exceeding 100 beats per minute, and sometimes this can be even at rest. The causes of sinus tachycardia can be from a response to a condition or a disease, from drug use, fever, excessive thyroid hormone, exertion, excitement, low blood oxygen level called hypoxia, stimulant drugs like caffeine, cocaine, and amphetamines. But however, in some cases, sinus tachycardia can be a sign of heart disease, heart valve failure, or other illness. Sinus tachycardia symptoms. Usually sinus tachycardia is asymptomatic, and that is that the condition does not result in any visible serious symptoms. But minor problems can include a racing heart or palpitations, feeling of the heart pounding in the chest, dizziness in some cases, syncope, consistently fast heart rate, above 100 beats per minute even at rest, periodic chest pain, sometimes sharp, others constraining, and chest pressure, out of breath, increased fatigue, intolerance to exercise or any type of physical activity. Sinus tachycardia diagnosis would be with the heart rate from 100 to 100 times per minute. The EKG examination basically shows that there's an increased heart rate, and that's the most significant characteristic. So if you look down at this EKG example, it shows that there's multiple P waves close together in time, and that shows that there is a fast heart rate. And a lot of times with a sinus tachycardia, there'll be T wave and P waves close together, and sometimes those can be hard to distinguish from each other. The treatment of sinus tachycardia, it rarely requires treatment. The underlying causes can be anemia, infection, hyperthyroidism. Rarely the sinus node can cause the heart to beat faster than it should without any underlying cause. If symptoms result, the condition is known as inappropriate sinus tachycardia, and some treatment options are available. Looking at sinus tachycardia on the EKG. Here, looking at lead 2, you can see that there is an increased amount of P waves within, and this is showing that there's an increased heart rate. You can also see that the T wave and the P wave are hard to distinguish from because they are so close together. And if you look, the heart rate is up to 140, showing that there is a very fast heart rate.
Next, we'll be talking about myocardial ischemia. It's defined as severe impairment of the coronary arteries that leads to metabolic and ultrastructural changes that lead to irreversible injury. This is due to lack of oxygen flow through the arteries, also known as atherosclerotic arteries or blood clots. This eventually can lead to a myocardial infarction, cardiac arrhythmia, and contractile dysfunction. Some risk factors: diagnosis of hypertension, which is associated with many problems of the heart because it has to work so hard to pump blood to the rest of the body. Hyperlipidemia, which contributes to the buildup of plaque in the arteries. Diabetes, atherosclerosis, and heart failure. Some other diagnoses are aging, smoking, sedentary lifestyle, obesity, and family history. Some symptoms are chest pain, pressure, typically on the left side of the body, neck or jaw pain, shoulder or arm pain, clammy skin, shortness of breath, nausea, or vomiting. Some treatment that can be done for myocardial ischemia is to aim to improve blood flow. May need medication or surgery or both. Some medications that can be taken are aspirin, nitroglycerin, beta blockers, lipid lowering meds, calcium channel blockers, and ACE inhibitors. Nitroglycerin opens up the blood vessels, allowing blood to flow to the heart easier. Beta blockers help slow the heart rate and relax the heart muscle. Lipid lowering medications lower the LDL content in the body, helping to control the amount in the blood and arteries. Calcium channel blockers block the influx of calcium into the cells that cause the muscle to contract, therefore relaxing the muscle a little more. ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 causes the blood vessels to constrict, so by inhibiting this, we can prevent excess tension in the heart muscle and lower blood pressure. Some other things result from surgery, such as stenting, bypass, or angioplasty. Stenting: a stent is mesh tube-like structure that will hold the artery open when inserted. A bypass is when the surgeon takes part of another working blood vessel and uses it to form a bridge completely overlooking the blockage, so blood is no longer flows through the injured artery. Angioplasty is when a balloon-like structure is inserted into the blocked blood vessel and expanded. This compresses the plaque against the artery wall and opens the artery up more so blood can flow through. Some prevention is to avoid smoking, exercise, maintain healthy body weight, reduce and manage stress, control conditions such as high blood pressure and high cholesterol. On this slide, it shows an EKG of a myocardial ischemia. As you can tell, this is from a ST depression when the ventricles are depolarized. As you can see on lead 2, myocardial ischemia is a depression in the ST segment, which is shown right after the QRS wave.